particularly in our country. When you see large confluent granulomas as opposed to ill-defined small granulomas, you certainly have to keep TB in mind. And that's something that I think in India we need to always be conscious of. Even without caseation, because it's just a little factor where you'll keep your mind open about TB. You won't say just because everybody else had Crohn's that she has Crohn's. What about surgery? What about the lyric trial?
One thing, being the odd man out, being a surgeon in a medical forum is quite difficult. But again, majority of the patients who are generally treated by the physicians first, and the combined decision and the counseling regarding surgery starts there. It doesn't start from the surgical side. Yes, we do have the lyric trial in 2017, which showed an early laparoscopic ileocecal resection versus infliximab. They had comparable outcomes. Especially if actually seen with the physical parameters, they had better outcomes with the laparoscopic ileocecal resection kind infliximab. But yes, when they are comparable, we can give the option, but I'm not sure how practical it will be, given the status of flow the patient has.
So for those of you who are not familiar with the lyric trial, as Dr. Gautam was saying, this is limited ileocecal resection, and they compared it with, and this is non-obstructive disease, non-perforating disease.
Non-emergent,
But I think one imaging you should give us. Either give us an MR and
okay, forgive me for this, but we are going to go down the track.
So can I just make small
So
comments?
it's not stopping here, the story will evolve a bit.
So every panel, there are 3 or 4 gastroenterologists and 1 surgeon. So I've been thinking why this is so. Then probably I realized that it has to do with the income parity. So 3 gastroenterologists is equal to 1 surgeon. So that is my explanation. If somebody has other explanation, please.
I'm sure that will find a lot of resonance in this room. we have another very senior surgeon here, Dr. Ahmed Ali. So, I'm glad to see that Gautam is not too gung-ho about going to operate on this lady, and that's very reassuring. So, what happened was that this patient actually refused biologics. We suggested biologics, and let me explain to you why we would even think of that. Because this is a relatively young lady. She had her life ahead of her in terms of going to get married, having children. So if she could be spared steroid side effects, not be disfigured by the steroids, etc., there certainly is value in considering biologics if her social circumstances would allow that. But, her social circumstances didn't, and she decided not to go with biologics. So she was treated as usual with corticosteroids, with mesalamine and azathioprine. I saw her again in 2018. She continued to have endoscopic lesions. The reason she came in 2018 was that she had acquired a boyfriend and she was going to get married. And she wanted to know what's happening with the disease. So she continued to have endoscopic lesions. Biopsies showed confluent large granulomas still. So at that point of time, we took her off. She was off steroids, she was off mesalamine, she was only on azathioprine. And already she had kind of made up her mind that she was going to stop all medication. She went back in the latter half of 2018, she stopped medicines. She got married, she had a baby, which was delivered by normal vaginal delivery in 2020. So she was kind of lost to follow-up for a couple of years. In 2021, she came back because she had pain in the lower abdomen and she had lost a considerable amount of weight. As you can see, she had a microcytic anemia with a hemoglobin of 6.5, platelets were high, ESR was high, iron deficient, and but albumin was normal. Colonoscopy again showed ulcers and a stricture in the terminal ileum with destruction of the ileocecal valve. Maybe I'll just pause for a minute here because Destruction of the ileocecal valve is something that traditionally we have taken as an endoscopic sign of tuberculosis rather than Crohn's disease. But here, we'll see how this story evolves here. The biopsy showed extensive ulceration and necrotizing granulomatous inflammation. I think, did you ask for caseating granulomas? They didn't say caseating granulomas, but they described it as necrotizing granulomatous inflammation. So while waiting for the TB results, we started on 4-drug antituberculous treatment because she came, she had her things, she wanted to go back. And she was given parenteral iron because she is usually iron deficient. So, may I ask for comments from the panel?
So here there was strong doubt. So 2 months of anti-TB treatment followed by a repeat colonoscopy would be what I would do.
I think in India it's good, but then little more details about the rest of the small bowel. If we know, it will be always better. So suppose you see nodes or you have a thickening or mesentery thickening or you have features of this. But I think starting anti-TB when you're in doubt, especially in India, start and then recheck and then continue is accepted. But I think small bowel studies have to be completed because this is stricture. So the length of the stricture, what is it, is the jejunum involved, everything has to be analyzed. And upper GI also has to be done before we.
So I don't think at this point I have notes on an upper GI, so I didn't put that in here. So I don't know if it was done. I don't remember if it was done.
No, I agree. I think small bowel imaging, probably MR or CT in someone this age would be important, both in making your decision initially whether to do azathioprine or biologic. I would use an MR there. And someone with extensive small bowel disease, I would probably go towards biologic. If they had, maybe a few inches of mild ileal disease, I would be fine with starting azathioprine initially. So I would want to see sort of how the MR is here.
So this again kind of highlights some of the social circumstances with our patients. They come, they have a budget, they have a limited set of investigations done, and then they go back. So this is something that we have to live with. I'm sure you have different circumstances where you do the same. You talked about the elderly, where you compromise on a number of the steps that you would normally take. And so that happens here as well. So, Gautam, I think you wanted to say something.
Yes, I think when we started the second part of the story where the patient started refusing biologics and was not adherent to the treatment plan, I think that is the time again surgery could have been counseled about, because it is not it's a medical disease. Still
the lyric trial wasn't published at that time.
Probably, sir. I know the patients, again, with a limited budget, every time they come in, they are not prepared for anything mentally for surgery. And then we still, even after surgery, you might need medicines. Yes, it is a difficult part of counseling, but I think with a patient who had a possibility of non-compliance, we could have given that option.
Sir, I would like to, Dr. what Ashwin was telling. So you said that if it's a very short stricture, you will go for ASA, and if it is a very long stricture, you will go for infliximab, biologicals. So can you highlight it, sir? Because clinically patient is relatively stable, but imaging shows short strictures here and there on MRE. That is one group. Other one is a long stricture. Do you vary your, you will not go for biologicals, huh?
No, so this was more for the first part when we were deciding whether to do top-down or step-up treatment.
That's what I'm asking.
So if someone had bad perianal disease, if they had deep ulcers on colonoscopy, or a long segment of involvement, where worst case scenario, if the drug doesn't work, they're going to end up losing a large segment of their small bowel. If they had like matted loops of bowel, where if you take them for a section, a lot of healthy bowel is going to be sort of injured and potentially lost. Those are the people where I would absolutely start with the drug which has the highest efficacy. So them, I would start upfront on combination biologics. In someone who doesn't have any of those features, then I would give them all these options. You could either do biologics, you could do budesonide and azathioprine, and we'll assess at 6 months, or whichever of the biologics you want. So that would be the stratification to start.